welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, I am Isabel Olivera, a medical writer for EHA. Today, we are thrilled to have Dr. Jan Moritz Middeke, a distinguished hematologist and AI specialist. We're going to be talking today about AI to accelerate clinical trials. Welcome, Dr. Middeke. Can you please introduce yourself?
Hi. Thanks for having me. I'm Moritz Middeke from the University Hospital in Dresden. I'm working there as a hematologist and have a research group on AI in hematology.
So we want to understand how you can accelerate clinical trials by generating data with AI. Can you please explain first what is synthetic data?
Synthetic data is, as the name says, data which is made up. And the idea is that we face a big problem with clinical trials in general, but especially in hematology, where a lot of the diseases are rare diseases. For example, acute myeloid leukemia is a rare disease per se. And we already know that there are several subgroups with targeted therapies. So the number of patients we can include in clinical trials are even lower. And therefore, we need to think about new ways how we can accelerate how we perform clinical trials in order to get sufficient data to get the knowledge about novel therapies.
So what types of synthetic data are you generating that could be used for clinical trials?
So the idea is that you have synthetic data which is reassembling the original cohort in a most perfect way, but without being able to get back to the original data.
So you're generating images?
This can be used both for images, but also for tabular data. And what we did in a recent study, and also other groups have shown, is that you can reassemble real clinical trial data in terms of baseline data, but also in terms of outcome results based on cohorts of real patients. And the synthetic data is reassembling all the information about the original patient, which is like age, sex, but also molecular changes, and then the outcome after a given intervention.
And how do you generate this synthetic data?
So for this, we used GANs, generative adversarial networks, which is a known form of AI which has been used for image generation, quite successful already, but can also be used for tabular data. And in our specific work, we use two types of these, so NFlow and CTAP-GAN.
So these are types of deep learning and generative modeling. You have described 4 scenarios in which synthetic data generation can be useful. And I would like to walk through this for the audience. So first, AI-generated data could help to prevent privacy concerns about clinical trial data of the patients.
Exactly. So the generated synthetic data can be shared without any privacy issues. So we checked that there was no single patient in the synthetic cohort which was exactly matching the original patient. So there's no way that you can go back to the original patient, which of course is the case if you just have anonymized data. So this makes it really easy. You can just upload these data and make them available also for other research group and the public.
So how does this compare to the de-identification or anonymization of patient data?
So anonymization of these data isn't 100% sure. And with the synthetic data, it's 100% sure. So there's no way that you can go back to the original patient because there's no original data coming from one single patient. So it's basically 100% sure that you can't go back to the characteristics of one single patient.
So this is a big step forward for this kind of data. Also, you would create new patients, and this would lead to either cohort augmentation, so some synthetic patients among patients that are real, or completely a substitution and you have a complete new cohort. How robust is this process?
So for the generation, it's very robust. We showed, and also other groups, Matteo Della Porta did this for MDS, showed that it's reassembling the whole characteristics of the patients for a given disease. So it's not only age and sex in terms of the distribution, but it also comes down to the molecular changes, which is very important because we know that there are certain relationships between certain mutations. So, for example, if you have an NPM1 mutation, you are more likely to also have a FLT3 mutation. And these correlations are preserved in the synthetic data set. And this holds also true for correlation between age and certain cytogenetic abnormalities like complex karyotypes with higher age and so on. So biologically important correlations are preserved within these data. And even more important, this also holds true for the correlation to the outcome data. So known factors for poor or good prognosis are also preserved in the synthetic data. So if you have a patient with complex karyotype, he also has a worse prognosis in the synthetic group of patients. And this is super important because if we want to use them as a real control group, we have to make sure that this is also like in the real world.
So there is also a use for exploratory analysis to synthetically enlarge datasets. What is the interest of this?
We know that there are several important subgroups when we stay in the case of acute myeloid leukemia, certain molecular subgroups which are recurrent but are rare. And so for these group of patients, it's of course very important to know how they fare with a certain therapy. And with a synthetic generation of data, you can substitute or enlarge these rare subgroups.
How reliable is this process? We have all heard about hallucinations in AI. Can this generative AI generate misleading data?
Well, of course, you always have to show it for a given group, but for the examples I mentioned, this is very robust. So there are some small differences, but in general, this is very robust in terms of how the baseline distribution of characteristics is, but also for the outcome data. However, especially when the outcome events get lower in the training group, this leads to a lower robustness of the model. So there are still open questions where we have to work on.
And the last case you mentioned where this kind of synthetic data can be used is in model training or benchmarking. Can you explain this further?
So the idea is that we also have to generate data for rare subgroups. And for that, we can use synthetic data to enlarge the group of patients, basically.
In clinical trials, these generated patients are called now synthetic patients. Can you summarize what the advantages to use this kind of synthetic patients?
We have to point out that so far, synthetic patients have not been used within clinical trials. And I believe that there's still a lot of work to do also from a regulatory aspect to show that this is really feasible. On the other hand, we know that the generation works. And the problem is so big that we have to think of new ways how we can accelerate clinical testing. And so for this example, we used only intensively treated acute myeloid leukemia patients almost without targeted therapies. So this has to be shown with targeted therapies. This has to be shown with real life data and with certain intervention. And there's a lot of work to do before we can really say, okay, so we augment one group of patients within a clinical trial for, in the end, leading to an approval or identification of a certain efficacy of a given drug.
So really is work in progress. How closely does these cohorts match real world cohorts?
Okay, that's a difficult question because it hasn't been shown yet.
So for the moment, you don't know really how well, and it's being tested.
We know how well it matches for a given group of patients we studied or other groups studied, and there it is working well. However, we have to prove this for real-world cohorts and certain interventions.
So the idea would be to use these cohorts mostly in the control group in a clinical trial at the beginning at least?
Yes. I think this is the most realistic and closest scenario, that we use this as a control group, an enlarged control group, yes, with a certain intervention.
Which would be interesting because then you don't have to assign patients to a control group. So you mentioned the regulatory considerations. We have some tools at the moment, like GDPR or HIPAA. Are they enough to address the potential issues that this kind of synthetic patients would bring?
Well, I think this requires complete new thinking about the approval process and the way we look at clinical trials. We need a way to prove that this is really working, and I envision this in the first place to go alongside clinical trials. And this is also what we are currently doing. So we are going back to clinical trials we already did, and we are going to see how many patients we can substitute by synthetic patients to get the results we already know. So for me, this is an important step to show how we can incorporate synthetic patients in real clinical trials. And I think this step has to be done in close contact with the authorities, that we together define criteria where we say, okay, this is working, and we can move on further.
So if you had a crystal ball and could see what the future holds in 5 years' time, do you think it's going to be used a lot?
Yeah, well, 5 years is close in clinical testing, but I know that the way we did clinical trials in rare diseases like acute myeloid leukemia in the past is over. So there won't be clinical trials with like 1,000 patient randomized with a certain drug, because in the meanwhile other drugs are coming up. We gain further knowledge. So this is getting harder and harder to perform these large trials. So we have to adopt new methods. And I think synthetic data is one very promising way, but there are several steps before we can really say, okay, that this is working and enhancing our clinical testing.
Are there other uses of this data that you are now developing for prognostic capabilities in hematological malignancies?
So coming back to images, this is another interesting field where we can enhance the amount of images for rare subgroups of patients. So basically doing the same thing for small subgroups within clinical trials. We can also do this for images of bone marrow smears, for example.
This is already being used.
Well, I wouldn't say it's been used, but it's like we and others have shown that this is working, and that you can generate synthetic images based on real bone marrow smears, and that you can't really tell which is a synthetic or a real bone marrow smear picture.
And these are being used to train?
Well, it hasn't been used, but that's the idea. So the idea is that you can generate more data and then increase model development.
So in the future, you think that you will go beyond the control group, so you would use the synthetic data also in the test group?
The improvement of the techniques is so fast that we can really simulate what is going on within a single cancer cell with a certain intervention. And with that, I believe that in, I don't know how many years, but in the future, we will be able to also simulate what will happen to a certain group of patients when we give the drug X.
Yes, I'm a biologist by training, and I find it difficult to imagine that you will be able to reproduce this complex system in its totality. But I look forward to it. It would be fantastic.
Yeah, agree on that. But 5 years back, you probably would have said that in predicting protein structure, which is now working almost perfectly. So, yeah.
No, I think it's really promising, and I really hope this works, because it would help enormously in accelerating clinical trials and treating better patients. So thank you very much, Dr. Middeke, for sharing your insights and your experience with us. Thank you to everybody for listening. And if you like this episode, don't forget to like it and share it with your colleagues. And stay tuned for our next episodes. Thank you.
Thank you.